Hi, good morning, everyone. Welcome to our Unit 2 discussion. Today we're going to be talking about general supplies used in surgical cases. So there's a lot of things that we're going to have to cover because there are a lot of supplies in surgery. So let's talk about our objectives here real quick. So we're going to talk about using a variety of surgical supplies used in surgery, sutures, sponges, dressings, catheter, all of that. This right here, before we move on, is called a red sharps box. They can be this size or they can be slightly smaller, but typically the idea here is um, it keeps track of obviously your sharps, right? You want to keep your sharps contained so it's not a safety hazard, but it's numbered here so you can put your suture needles right in those slots so you can help with counting. Your scalpel blades can go here on this magnetic strip. And the back of this foam numbered piece is sticky, so you could make sure that that stays secure to the back of the sharps box. So I wanted to point that out before we move on because I went ahead and put the picture here. So our assignments for Unit 2 are, you got the typical discussion, talking about the soft supplies, couple quizzes and knowledge checks. I know it's already Thursday, but just to remind you for next week, make sure your discussion posts are due on Wednesday. That gives you enough time to turn around and respond to two of your peers by Sunday. So make sure you're responding to two people for full credit and making sure you're citing your sources properly using APA format. I can post a link for that or you can contact me if you're struggling with how to cite your sources in APA format. Okay, so why is it important to not only know what certain items are used for, but also how many should come in each pack? So that's something we're going to talk about with supplies. You'll hear that a lot. You obviously have to know what they're used for so you can use them appropriately, but some items come in a set amount per pack. So why would that be important? Well, you have to know what your base is if it's a counted item. That way, if there's something that is missing, you know what should be there. So when we are talking about especially sponges, that's usually the big one, and sharps, we want to make sure that we know what the base count is, what I should have. So if I get a pack that should have 5, but I only have 4, what happened? What should I do in those instances? You have to have that foundational knowledge because it like this says here as part of your objectives is to start that critical thinking skills also works with anticipation of the surgeon where we're working in the operating room. So it gives you that base knowledge of what you need to be effective. So let's get into some of these. So our soft skills, or not soft skills, we talked about that already. Soft items, excuse me. So typically we're going to talk about sponges when we talk about soft items. These are 3 of the main ones, and then I have a couple more for you here in a few. So the first one here are laparotomy tapes or lap sponges or just laps. Sometimes you'll hear them a couple different ways. At least with what I'm most familiar with from what I've heard from other people, we often abbreviate it laps because who has time to say laparotomy tapes? So we say laps a lot. So the purpose of laps are to absorb larger amounts of fluid because you can see here, over here on the right side, that these sponges are pretty thick, pretty big. So they can absorb larger amounts of blood or fluid, used often in like big open abdominal cases, things of that nature. They come in packs of 5. So like I said at the beginning, these are countable items. A lot of our sponges are. So these come in packs of 5 and when they are packaged, are contained with this little paper strip. So I always tell my students, don't break this strip until you're ready to count those items with your circulator. That way it gives you a visual. I haven't counted these yet. I know they're all here. Nothing has gotten lost until you're ready to count them. Okay, that's important. You don't want to accidentally lose one before you ever got the chance to count them. Stranger things have happened, okay? So packs of 5. Sometimes with our sponges, they are also X-ray detectable. If it's going to go inside the wound, any incision we've made, it needs to be X-ray detectable because what could happen, you're closing up that case or that abdomen and you're trying to count those sponges again to make sure you have them all and you're missing one. What do you do? What do you do if you're missing one? You only have 4, but you should have 5. The first thing you should do is recount, because sometimes we're human, we make mistakes even in counting basic 1 through 5, okay? It happens. You miss one. Maybe it fell on the floor. The next thing you should do if you still can't find it is to alert the surgeon, because they're going to have to stop what they're doing, make sure they don't close that item up in the abdomen or wherever you're working. Okay, if for some reason, after all that, you still cannot find this lap sponge or any sponge, what we can do is call in an x-ray tech. They're going to bring in a mobile x-ray unit that we can put on each side of the patient. It takes a picture of the patient, and should that sponge be inside the patient, this little, kind of hard to see it, this little blue strip right here, see it here too, this blue strip is x-ray detectable. That strip is what's easily going to show up on an x-ray if it's in there. So we have to have x-ray detectable items if we're going to put it inside the body for that reason. All right, the next one are Raytex sponges. Sometimes we call them Raytex, or some places do call them 4x4s. I wouldn't get too hung up on that one because some places also call dressing sponges 4x4s. So just to alert you that you may see that. More often than not, we're just going to call it Raytex. Okay. So Raytex are smaller and thinner than these laps. Okay. Raytex absorbs smaller amounts of fluid, and there's more in a pack. They come in packs of 10. Every now and then, the manufacturer makes a mistake, you get a pack of 9. In that case, if you haven't started that case yet, you should get rid of that pack of 9 and put it off of your sterile field. Your circulator will bag it, and it never goes in the trash, ever, okay? Because if you lose it, you might have to look through the trash, and then you might think it was part of the case. So we have to, like I said, keep track of everything. If you can't just keep going with your pack of 9, because later when you're doing maybe a closing count and you only come up with 9, we are so in the habit of thinking there should be 10. Okay, so you always want to do things the same way every time to eliminate mistakes. So keep your pack of 10. This one is also X-ray detectable. I misspelled that. There should be a T. Detectable. This blue strip here is detectable. And then it has the same concept here with this paper strip that you keep on until you're ready to count. So whenever you're counting these, just FYI, there's going to be, you can kind of see it here, a folded over edge, okay? It's easier to grab onto that folded edge when you're ready to count. Otherwise, you're going to be fanning them out. It's going to be a lot. And you have to separate each individual sponge when you count. We'll go over counting probably at another time. All right, another soft item are dressing sponges. I grouped it here because this, you can look here in this bottom right corner, this dressing sponge looks very similar to this Raytex sponge. The only difference is the dressing sponge is not X-ray detectable. So therefore, it should not be opened at the beginning of the case. You will see people do it. It's a bad habit. You shouldn't do it. You should open all of your dressing supplies at the end of your case. And the reason for that is because it's not X-ray detectable. If this accidentally gets shoved into the abdomen or, any spot really, and it becomes bloody, when these Raytex and dressing sponges become so absorbed with blood, they end up being so balled up and tiny, like super tiny. You can't see them. You'll never find them. So without that X-ray strip, it'd be even harder to find. It looks almost like a blood clot sometimes when it's so balled up. So open them at the end of the case. They are for dressing the incision at the end. So there's really no need to open them at the beginning. And sometimes you would even change the surgeon may change what type of dressing they would want anyway. You might end up with a different type of incision that was planned. So it would be a waste. You don't want to waste items either. So dressing sponges can come in a variety of sizes and shapes. This is just your basic 4x4 dressing sponge. It does absorb some fluid. All right, some other soft items. 3 other very common ones here. Tonsil sponges. As far as I'm aware, they don't have another name. We just call them tonsil sponges. They do come in a pack of five little balls here. So they're like they almost look like a Raytuck that has been just balled up and secured that way with a string attached. These blue strings here are X-ray detectable as well. So packs of 5, they're used probably most often in tonsillectomy procedures. Whenever they take the tonsil out of the back of the throat, they're going to use this to apply pressure right where that tonsil was because they do tend to bleed, and then remove it with the sponge. So the sponge will actually hang out of the mouth. And they're doing that so it doesn't accidentally go down the throat. So you'll see those most often there, tonsillectomies. All right, our next one, these are very small, okay? It's kind of hard to gauge by this picture, but these are called cottonoids, or often called neuropatties, but you need to know both terms. On your certification exam, you'll probably see something about cottonoids. Okay, so if your facility only calls them neuropatties, just make sure you understand they are both the same thing. So cottonoids absorb very small amounts of fluid because we're talking these things here, and I put the sizes, these are actually sizes right here, are very small. So these are all measured in inches. Okay, so this one right here in this picture is a 1/2 by 1 inch neuropathy. Okay, use your knuckle, right? This little part of your knuckle is an inch. That's how I remember. It's easy. So this is 1/2 inch wide by 1 inch long. These are also X-ray detectable. You see this blue strip here. These come in packs of 10. So these are a little trickier to count because you want to make sure that the sponge is there, but you also want to make sure the sponge is attached to a string, because these are going to get placed in maybe near the spinal cord or the brain if we're doing a craniotomy. So the surgeon will often maybe pull onto the string to pull it out. You don't want to lose something that small in the brain or spinal cord area. So they can be easily lost. They even go down to something as small as a 1/4 by a 1/4 inch, which is super small. We don't use those as often around here. Most often, I'd say it's 1/2 by 1/2 or 1/2 by 1, maybe even 1/2 by 3, which is the same width, but 3 inches long. And you might have a variety. You might have 3 or 4 different sizes, all in the same case. And the surgeon would just choose off of your neuropathy board which ones they want. So these are often moistened and placed on just a flat metal board that the surgeon can easily pick what they want during the case to use in the abdomen or in the wound, I'm sorry, the incision. Whenever the surgeon gives it back to you and it's bloody, you will then use that string and place it through this tiny little slot here on the one side. So once they're used, you're going to use the same card to count them, to keep track of how you're going to count them. So never throw this card away that they come on. You should use it to count those at the end. Okay. Also, we not only use it to absorb, but especially on the brain and spinal cord, those are such delicate areas anyway. So if the surgeon needs to suction any amount of fluid or blood, they'll often place that cottonoid or neuropathy down first and then suction over top of that cottonoid sponge. That way they're not suctioning like directly on the brain. That can actually damage the brain or, suck up a piece. No one wants to suck up a piece of brain. So you're going to place that cottonoid down first, suction directly over top of it, and it'll still absorb and be able to suction fluid that way. All right, this last one here is called Telfa. It's kind of hard to see with that white background. That's my bad. But it's kind of shiny and smooth, but it can be used, it kind of has dual purpose. It can be used as a dressing, and if that's the case, open it at the end. Or you might get it in your pack on your back table normally to be used for specimens. If you think you're going to be doing maybe you're taking out a lot of lymph nodes, or you're going to have a lot of different types of specimens, you can use this Telfa to place your specimens on, which is then going to help you put it into, whatever proper specimen container that you may have. You can cut these telpas into smaller sizes. If you have a tiny little lymph node, you might be able to cut this into 5, 6 pieces, just to use, and I wouldn't cut it for necessarily um, a dressing if I could avoid it, but I would typically cut it for specimens. You could also label those with your marker. Okay. All right, so we talked about Ratex. What's interesting about Ratex is it can be used to absorb small amounts of fluid, but these types of sponges can also be used to be loaded onto a Forester sponge stick, which I'm going to show you here in a few. And in that case, it's either going to be used for blunt dissection or absorption, maybe often in OBGYN cases, especially like vaginal hysterectomies, DNCs, something like that. So what we mean by blunt dissection is instead of using scissors or something sharp to cut through tissue, to make your way through tissue, you can use a sponge and like push your way through certain tissue. Obviously, not all tissue can be done with, but it's a little bit easier on the patient to do blunt dissection as opposed to using scissors. So this YouTube account here, Surgical Counts, has a lot of good tutorials how to do certain things. I think the guy's name is Mark. He's really nice. He's a good guy. And he has a nice video on actually 3 different ways to load sponge sticks. So I was taught one way to load a sponge stick, but maybe in your facility, they do it a different way. So I wanted to show you a couple different ways that this can be done.
So I'm going to show you 3 different ways to create a sponge stick. Now a sponge stick is a Forester clamp wrapped with the end wrapped with a Raytec so that it can be used for several different reasons. One of the reasons we might do this is for absorbing a little bit of fluid that might be in the wound that we've created, maybe to apply pressure to a bleeder in the wound, or most commonly for some blunt dissection, just so we have a nice soft tip on this so that we can bluntly push some of the tissue out of the way. So we're going to create a sponge stick that will allow the surgeon to do this. Now we start with the Forester sponge stick. Now I have 2 different sizes here, a smaller one and a larger one. I prefer the larger one. And there are 3 different ways to create the sponge stick. 3 different ways to wrap the Raytec around the end so that it stays on there securely and it does what we need it to do for the surgeon. So for the first method, which is the most straightforward method, it's probably the fastest method to create a sponge stick, is fairly simple. What we're going to do is we're going to take our Raytec and we're going to fold it into thirds. So we're going to fold it into 1/3 and then a 2nd third. So now we've got it folded into thirds. And then with the blue stripe on the outside, we're going to fold it in half long ways. Then we simply take our sponge stick and clamp it onto the Raytec, just like that. Now notice how I've positioned the sponge in the clamp itself. There's about a centimeter of the sponge sticking out above the ends, above the tips of the clamp. That way, when it's used against the tissue, it's not pressing, the metal is not pressing against the tissue itself, but also the sponge itself is not too floppy. Now you want to be careful that you don't load it so that the metal tips are too close to the end of the Raytec like I've done here. Because then if you go to dissect against that tissue, the metal tips themselves are actually touching the tissue. And the whole idea of having the Raytec here is so you have something nice and soft, not something hard like the metal tips. So you want to keep those metal tips away from the end of this Raytec just a little bit. But you also don't want to load it so far back that the Raytec then becomes floppy against the tissue that you're pushing against. So you don't want this Raytec sort of flopping around like this. So a good load is going to be maybe a centimeter or so down. It's going to look something like that. That's going to be a good load. It doesn't flop around too much and it gives you a lot of pressure that you're able to apply against that tissue. Now a second way of creating a sponge stick is going to start out very similar. What we're going to do is again fold our Raytec into thirds like this. Then we're going to turn it over, making sure that the blue stripe is on the outside. We're going to lay that down and take our sponge stick and lay it into and across the middle of this folded Raytec that we have. And we're going to take the edges and fold them up and squeeze them into very tightly pack it down there and hold it in there with your fingers while you clamp down, wrapping the tips of the Raytech all the way around like this. Now again, the blue stripe is showing. Why do we want the blue stripe showing? Because we want it to be obvious to everybody in the room that this is indeed a Raytech, which is allowed to be used inside the body. It's not a 4x4. So having that blue stripe visible to everybody makes it clear that this is indeed a Raytech and we're allowed to use it. Now, one advantage to this fold is it does wrap all of the metal completely in that Raytech, so there's no metal exposed. And very importantly, we want to check the end to make sure that there's no metal sticking out, because if you loaded it too close to the end, then sometimes that metal could come out, and when you go to press it against the tissue, the metal could actually protrude a little bit, contacting the tissue. We don't want that. We want that metal completely covered by the Raytech, and that's what we have here. Now the third method of creating a sponge stick is probably my favorite. Now there's a little bit more origami involved, so it might take just a hair longer to create one of these, and if you're in a rush, maybe you don't want to do that, but once you get a lot of practice at this, it becomes pretty quick and maybe only takes a second longer. And the advantages to this particular method is that it completely covers the metal ends of the sponge stick so that you don't have to worry about them coming out. And it looks kind of nice as well, and it's kind of fun to make. Now here's what I'm going to do. I'm going to take the Raytech, and instead of folding it into thirds, I'm actually going to fold it at a diagonal. And not quite a full diagonal, so this corner tip here is not going to quite touch this corner. It's going to be back just a little bit, so it looks something like this. And then I'm going to take my clamp, place it in the middle just as we did before, fold the sides over, putting them into the clamp, and then folding this top corner over and placing that into the clamp as well. And we're going to stuff all of this into the clamp before we squeeze down, and we're going to make a nice tight ball around the end of this clamp. Now there is no way for these tips of the metal to protrude through because we've wrapped the top as well. So this is kind of a nice sponge stick, and it makes it a nice solid sponge at the end of this that we can go in all different directions as we move that tissue around, or maybe absorb a little bit of moisture or fluid that might have gathered in the wound. Now, as you start making your sponge sticks, you'll probably find that you have a preference as the one that you like to make. But also remember the amount of time that it takes to make these. Again, this one takes maybe a second or two longer than it does to take this one. And when you're in a time crunch, that can be important. But also, it's not necessarily just your preference, but it could also be the doctor's preference. Some surgeons have a preference as to the way they like their sponge sticks folded. So make sure you learn all three ways. That way, if you get one of those surgeons that likes it folded a particular way, you're able to make a nice folded sponge stick for them.
Okay, so hopefully that was helpful to see a couple different ways if you hadn't already seen how to make a sponge stick. I was always taught the first way, to do the thirds, fold it over one more time, and just clamp it. And I was actually also taught to put the blue on the inside, just because that tiny blue X-ray detectable strip could be a little harsher on the tissue. It has a little bit more of an abrasive feature than the sponge itself. So we were always taught to do it from the inside, but he makes a valid point that, you visibly can see the blue strip and it's okay to use in the patient. So, it's going to be dependent, like you said, on the surgeon, what your facility does. So you'll just have to adjust that way. Sorry if you can hear my lawn boy mowing my grass. He picked a terrible time. Sorry about that. So let's move on to types of syringes. I picked 4 here. There are others because at least these two come in different sizes. So you might see a variety of these, but these are kind of the 4 basics. So the first one here is a Luer lock syringe. So what makes this a Luer lock is if you look at the tip, you can kind of see there are like grooves here that your hypodermic needle will literally screw into and be secured. That's important when you're injecting medicine or local anesthetic, anywhere on the body. Otherwise, that needle can easily like shoot off if it's not secured. Okay. So the Luer lock, the 10 ml or 10 cc Luer lock, is one of the most common syringes you'll use in the OR. It is used for most cases for injecting local. You could use it to aspirate or draw out fluid. If that's the case, typically we use a bigger syringe. So you could have a Luer lock not only in a 10 ml, but you could have it actually in 12, 20, 30, or 60 ml. So you could actually even have it in 5 as well, or 3. But 10 is most common. If it were a 12, sometimes the markers do go up to 12. Me and my stubborn ways, I would still draw it up to 10 because if I have to keep track of my anything I'm using, local medicine, you have to keep track of that. I like to do math in tens as opposed to 12 because it's just easier, right? I'd rather think in my head in tens as opposed to 12s. So here's another example. This is a slip tip syringe. It's very similar to the lure lock except for the end. Notice here it doesn't have those grooves for your needle to lock into. So this might be better used for maybe vascular cases. If you've ever maybe gotten an IV or had to have, a needle put in or something, they can use this syringe with a needle attached, but it's easier to detach the syringe from the needle if the needle needs to stay in place. Okay, because sometimes we have to use needles to gain vascular access, but we need to take the syringe off to put something else in its place. Maybe you're going to keep the needle in the vessel, but put in guide wires or something else. Okay. So that is pretty often used in vascular. Honestly, that's probably when I've seen it most. I would never, if I were injecting local, maybe near the face or something, I would never use a slip tip because if you were to accidentally inject with a slip tip and the needle comes off and shoots off, think of where you're at. That needle could go in the eyeball, right? Or it could go somewhere delicate. So be mindful of that. These do come in a variety of sizes as well. 10 is pretty common for slip tips. You might even have a 5. It's a little bit smaller. So you always label your syringes, okay? These are not labeled. There's nothing in them. But you would place your label opposite of the numbers. So you don't want to cover the numbers. I know that seems self-explanatory, but I'm telling you because I've seen it done. So just to be mindful of that as well. So you could also put it on the plunger, pull it out and label it on the plunger. It doesn't fall off as easily. All right, this third one is called a baby bulb syringe. At least that's what we often call it. It doesn't have any markings really because typically we use it to irrigate maybe small amounts of fluid or to suction out, like it says, the baby's nose and mouth. So if we're doing C-sections, we will often use these right as soon as the baby is delivered, clear their airway, and then they can pass them on to the nursery nurse. So it's in the name, right? Baby bulb. This last one is an asepto syringe. This one is super common. You'll have this in a lot of cases, not just general. It could be ortho, neuro, it could be anywhere. So it's hard to see, but there are markings here, right there. So in this clear part, it holds 60 mLs or cc's. And in the bulb part, it also holds 60. So in total, this entire aseptic syringe holds 120 cc's or mLs. Cc's and mLs are the same thing. So we could use this to irrigate with normal saline or antibiotic saline, whatever it is. Always keep it full, as much to the tip as you can. That way you can, 120 cc's. That's what I've got. Whenever that surgeon gives it back to you, try to see A, it could be completely empty, or B, how much is left, and make note of that. You always have to keep track, just like with your local. Write down how much saline was irrigated with, okay, and then refill it. So those are 4 pretty common syringes you'll see. All right, let's talk about urinary catheters. So urinary catheters are to drain urine from the bladder. That seems obvious, right? But there are 2 ways that you can do that. One of them is considered an indwelling catheter, and the other is intermittent. So an indwelling catheter it indwells, it stays inside. So it stays in place inside the bladder for could be days, maybe just the length of the hospital stay, could be weeks, depending on the patient's condition. Indwelling catheters have to be attached to a drainage bag for continuous drainage. which is what this picture is here. So just to give you a basic idea of how a urinary catheter works, there's going to be some sort of eyelet or opening at the end of your catheter, which is where the urine will drain into from the bladder, okay? If it's indwelling, it has to stay in somehow, otherwise it would just keep falling out. So typically it's going to be a balloon that gets inflated from this balloon inflation port that once it's placed in the bladder, this balloon like sits on the base, the bottom part of the bladder itself before it goes into the urethra, okay? So this portion, the rest of it's called the catheter. There's also, you could take samples of urine through this port as well. If, you know, every so often they may want to pull a sample of urine for urinalysis. It's easy to do through this port. Usually it's a 10 cc Lorlock syringe, put it right there, and then you can just squirt that syringe into a specimen cup. Okay, the rest of this tube is from this collection bag. These bags can look a little bit different. There's always going to be markings, so you can tell how much urine has been drained. There's always a spout to empty it. So, you know, if you see at the end of your procedure, you put in, let's say, a catheter at the beginning, and, you know, by the end, maybe this bag is completely full. Don't send them to pack you with a full bag, okay? Make note of how much was, you know, how much is in there, how much are you draining. Find something to drain it into. Often we'll use like an empty saline bottle. You may have to go get a basin, something that you have to drain it into. That way there's no backflow. If, you know, if it gets completely full and it flows back into the bladder, they could get an infection, a UTI. We don't want that. Okay, so an intermittent isn't going to look like this one. This is indwelling over here in this picture. Intermittent is just designed for a one-time use, and then you're going to just throw it away, okay? A good example of that is a Robinson catheter or red rubber catheter. It looks similar to this portion. It just doesn't have the balloon, and there's no port for inflation. It's just a straight catheter. We sometimes call it a straight cath, and then they'll pull it out after it's drained. So it doesn't have an attached drainage bag, but what you need to remember is once it gets into the bladder, urine is going to start flowing out of it. So make sure you have something to catch that urine with, okay? So a small basin usually works because sometimes at the beginning of surgeries, we have to straight cath the patient if they don't want to put an indwelling catheter in. Maybe it's a short procedure. Maybe we are taking off an ovarian cyst, for example, and we want to just make sure that the bladder is decompressed enough that you're not going to damage it. If the bladder is completely full of urine and you're in that area working, you're more likely to damage the bladder and put a hole in it. We don't want to do that for sure. That's a big ordeal, and it's a lot of pain for the patient we don't want to do. So we're going to drain the bladder if we're going to be working in that area, just to make sure that, you know, we can see and it's not going to get damaged. Okay, so here are some other examples of urinary catheters so you can see the tips of them. Notice this one's slightly different than the one we just talked about. The first one I showed you is a typical Foley catheter. Let me go back. This here is your typical Foley catheter, okay? Very basic. They come in different sizes like this picture shows you. This one here on the left is a three-way Foley catheter or three-way channel. Same type of tip, same idea, okay? But it has this extra port here. You have your inflation port, your drainage port, but this one over here is to hook up irrigation. So let's say we did a TURP or a TURB. That stands for transurinary prostate resection, or maybe a bladder resection, transurethral. So when we're taking out, you know, pieces of prostate through the urethra, we're scraping that out with a cautery tool called a resectoscope. You're basically burning out pieces of prostate from within, okay, because the prostate surrounds the urethra. So at the end of that, because there was a lot of bleeding, we want to make sure we can irrigate that constantly to irrigate any of that blood out. So this port you're going to hook up big bags of irrigation at the end of those cases. So it's for continuous irrigation and drainage. Okay, this one right here, this two-way channel is your typical Foley. They could put Foley here, but they didn't. Tiemann and Coudet are very similar, and you may hear them talk like named interchangeably there. They are angled types of Foley catheters. So they have a slight angle to them, and these are a little bit more beneficial to maybe male patients who have enlarged prostates. Sometimes it's really difficult to catheterize those patients. It's hard to get past that stricture, so sometimes these help in that case. So these sizes here, just to give you an idea, these are called French sizes. Catheters, urinary catheters, are measured in French sizes. So it is kind of how it seems. A 6 is small, okay, and then a 22 is large. So that is a little bit easier, but you should probably focus on these. Your adult female is typically 12 to 14 French and 16, 18 for males. So it gives you at least an idea or a starting point if the surgeon doesn't specify. Okay. So briefly about suture, and it is going to be brief because honestly, suture could be done as its own course. Okay. Students typically struggle with suture because it's overwhelming. There are tons of suture, and there are different ways to go about picking the right type of suture for the wound, okay? Because not all sutures are the same. They have different uses, and it's overwhelming, okay? Not to discourage you, but this is briefly just to give you an idea of different types of suture. They can be, it's kind of hard to see, but they can be natural or synthetic. There's different ways to group them, okay? They could also be absorbable or non-absorbable. They can be what's called monofilament or multifilament. So right here, this says mono. Right here, it says braided. Braided means multifilament. So with this monofilament type suture, it's literally one single strand of suture. You can feel it. If you run your fingers down, it's smooth. With this braided or multifilament, it's multiple strands, like twisted around or literally braided into, and you kind of see here in this picture, into one bigger strand. So you pick the right suture for the right incision. A lot of times surgeons do have preferences as to what type of suture they want for the specific type of tissue incision, because your skin, let's say, is not going to heal the same way as your bowel. They're two different, very different types of tissue. So the suture type has to be different. Some suture is absorbable and may absorb in, this says like 21 to 42 days. Some are absorbable in up to 238 days. It may take 238 days for that to truly absorb in the body. So if you have a type of tissue that heals very slowly, like cartilage, would I want to put something that absorbs in 21 days? Probably not. You're going to end up with that tissue not healing and breaking apart. So keep that in mind if you are ever like trying to figure out what suture the surgeon needs for this type of tissue, because it may be on your pick sheet or your preference card that this surgeon uses this suture for this particular reason, but you'll have it all on your back table and the surgeon may just say suture. They may just ask for their suture, and you're going to have to at least have the knowledge of anatomy to look at what they're doing and see, okay, they're closing the fatty subcutaneous layer. What type of suture would be good for that? Okay. They're on the skin layer, on the face. What type of suture would be good for that? So that does take some skill and practice, so don't be discouraged. What I would highly recommend that you do is get a chart or use your book. There's big charts in the book of these sutures and make note cards or flashcards out of them, or a Quizlet, whatever you need to do, whatever you like. Put the suture name. Sometimes there's multiple names. Put whether it's absorbable or non-absorbable. whether it's mono or multi-filament, and then maybe a couple uses, one or two good uses, okay? Because kind of hard to see because I inflated it here. But if you look up Ethicon suture or Covidian suture charts, you'll see them. So they'll give you a couple good uses. It's actually right here. So for example, surgical gut, sometimes it's called chromic gut, right here, chromic gut. It is a monofilament suture used often to close the uterus. If we're doing a C-section, we always close the uterus with chromic, at least where we are. Maybe Vicryl is also a good option. Maybe can be also used on the mucosa of the bowel. So those are good uses. Those are the ones I always tell my students. Absorbs in 90 days, okay? So that's what I would do if I were you. Take the time to make out these suture note cards, lots of them, okay? So make sure you get the other names for them too. Monocryl, it's kind of hard to see, is polyglucoprone 25. You can see it on this chart better. Now, up here at the very top of this chart are different companies that make different suture. Ethicon and Covidian are two of the most commonly used suture companies, but maybe you use one of these others, okay? So be able to say, okay, well, Vicryl is the same thing as PGA, okay? And even on your certification exam, you for sure need to know these generics because maybe in the stem of the question, it might say polyglucoprone 25 as something, okay? And then your options, A, B, C, D, might have monocryl P, this part, the brand name. So it is important to know both of those, all right? So that's a brief, very brief overview of suture, but I would take the time to make those types of note cards for yourself. It will take weeks and weeks of studying suture to memorize it, and I strongly suggest you do memorize those. Okay, briefly onto blades here. So these blades have different numbers, and you will be able to see these numbers in surgery. So, I mean, that is helpful. You should memorize what they are, though. This number 10 scalpel blade is one of the most common. We use that for, your most basic skin incisions. If we make an incision into the uterus for a C-section or maybe something in orthopedics, 10 is pretty common, okay? Now, 11 is a little more, you can see it's very pointed and precise. An 11 blade is often used for making maybe incisions into a vessel. We call that an arteriotomy. It could be used to make what we call stab incisions. Okay, we're not literally stabbing patients like, like this, but the incisions we make for trocars, like for a laparotomy or a lap chole or something, they're really, short and deep, like a stab wound. So we will use this type to make those small incisions for your trocar placement. This number 12 is unique. It's curved. It's not used as often, I will tell you that. So it's typically used for tonsillectomies because of its curve and the curve of the tonsil. It kind of like goes around that circle part of the tonsil very easily. It just kind of like makes that incision. Some docs don't do that anymore. They don't even use a 12 blade, but that's how I've seen it used most often. And then this number 15, it's similar to the 10, but it's a little bit smaller and delicate. You could use this for smaller types of incisions, maybe a little bit more precise, maybe some small plastics skin cases like mole removal or something like that. A 15 would work pretty well for that. So all of these numbers fit on what's called a number 3 knife handle because of the way that this little notch is. All these notches are the same. They slide right onto this handle very nicely, and it secures it. There are other types of handles that I didn't picture here, but another one is called a number 4 handle, which is really just a larger version of a number 3. So these blades would not fit a number 4 handle. You would have to get something like a number 20 blade, which is similar to the 10 but bigger, okay? Another common knife handle is a number 7 handle. It is just long and skinny, a long and skinny handle like the 3, but these all fit. 10 and 15, 10 through 15 fit that. There is this number 3 handle that is a long, we call it a 3L. Same end, it's just almost double in length. So if you're cutting deep inside the abdomen or, a deep cavity, you might need a longer handle if you need to make that incision. Okay. So that is our conclusion for some of these basic OR items that you're going to see. Make sure you memorize those because I'm telling you, you're going to see them daily. So get familiar with them. If you have any questions on any of those things, please let me know. Reach out to me. I like this little quote here. It says, at any given moment, we have two options, to step forward into growth or to step back into safety. So we're at week 2, and at this point, you're probably pretty familiar with how Herzing works, your online courses, but remember your goal here, okay? Keep pushing forward even if it's getting difficult. Maybe you're getting close to the end and you're tired. I get that, trust me. Keep pushing forward. You're stepping forward into growth, okay? Hopefully it will pay off for you and, you'll come out stronger and better on the other side, right? So reach out to me if you have any comments, questions, concerns, anything. I'll get back to you. We can set up an appointment if you need. All right. Have a great day.